We'll give it a little bit of time to click in, and then, hey everybody, welcome back to Morgellons discussion and microscopy videos. I'm your host, Jeremy Murphy, and today I'm very pleased to have a guest return on our show who is very educated in dermatology and
Are you muted? I don't hear anything.
well, what about now?
Perfect. I hear you now perfectly.
You know, these things happen sometimes.
Yeah.
Hey, everybody, and thank you for tuning in to Morgellons discussion and microscopy videos. I'm your host, Jeremy Murphy. Today, I'm very proud to have Dr. Steve Feldman back on the show. This is a second appearance here, and we're going to be talking about a lot of things relating to dermatology, dermopathology, and other aspects that affect Morgellons patients. And in case you didn't know, Dr. Steve Feldman said this: chronic skin diseases have a huge impact on patients' lives. We can help make great improvements in our patients' lives if they will use the medicine we prescribe. And that's a big if. Dr. Steve Feldman has opened our understanding of adherence issues in the treatment of psoriasis, atopic dermatitis, and acne. He is the author of over 700 MEDLINE-referenced publications and serves as the editor of the Journal of Dermatological Treatment. Dr. Feldman is a board-certified dermatologist and dermopathologist. He is professor of dermatology, pathology, and public health sciences at the Wake Forest University School of Medicine in North Carolina. He earned his MD and PhD degrees from Duke University in Durham, North Carolina, and then completed a dermatology residency at the University of North Carolina at Chapel Hill and his dermatopathology residency at the Medical University of South Carolina in Charleston. Hey, Dr. Feldman, how are you doing this morning?
Oh, I'm doing wonderfully. Thank you so much for having me on.
Yeah, thanks for coming back on the show.
Oh, always a pleasure.
So, have you been doing okay during the pandemic?
Oh, the pandemic's been very good to me. Yeah.
I see. Well, I see you got a lot of high quality things going on in your studio. You sound great.
Thank you. You too.
Yes, sir. Thank you. Yeah, you get the recording microphone, but I think so do I.
Mm-hmm.
So let's jump right into it. What is psoriasis? I mean, what is it? And does it involve skin lesions and even foot blisters?
Yeah. Psoriasis is an inflammatory condition where the body's making inflammation in the skin, causing spots on the skin that get red, thick, and scaly. And it's as though the body were trying to fight off some superficial fungal infection or something when there's no infection there. So there's pus cells, microscopic little collections of pus cells in psoriasis. On the foot, those collections of pus cells can get large enough to see. So you don't tend to see blisters in psoriasis when it involves the sole of the foot or the palm, but it can result in pus bumps, which somebody might describe as a blister.
Oh, yeah, that is very true. So they're not really filled with what is
Clear
the
fluid.
yeah?
Yeah, they're not clear fluid. There's more pus, white pus in them. And other areas that affect scalp, elbows, knees, belly button, in the crack, under the breasts, in the groin, or could be anywhere. Sometimes nail involvement is pretty common.
Wow. What about behind the ears?
Behind the ears would not be an unusual place to find psoriasis.
Does it follow the lymphatic system at all?
Not that I know of,
Gotcha.
but I imagine the inflammation that's in the skin probably does go into the lymphatics and move around the body that way.
Oh, wow. So, how do you treat it? What's the treatment for psoriasis? And is there a vaccine or maybe a cure?
No vaccine or cure yet. People would love that.
Sure.
Until then, we have treatment. So if you just have mild psoriasis, say a couple spots on your elbow or knee, topical cortisone medicines can be used. Vitamin D topically can be used. Topical tar has been used for a long time on limited diseases, or tar shampoo for the scalp.
Oh,
When the
wow.
disease is extensive, it's just not practical to try to treat it with creams and ointments. And so we do ultraviolet light treatments to the whole body, or some kind of internal medicine. One of the older classic internal medicines that we used for psoriasis was methotrexate. It's a
Whoa.
chemotherapy drug that would mildly calm the immune system down. You
Huh.
have to be pretty careful with it, make sure it wasn't causing damage to the kidneys or to the blood system or
Sure.
to the lungs. There's all these new drugs that are just revolutionary for psoriasis, and you'll see ads on TV for them constantly. And they're very effective and very, very safe treatments.
Oh, yeah. What do they? So they target the immune system and try to calm it down. Is that how these drugs work?
Yeah, so there's signaling molecules in the immune system that the scientists have discovered. Some of those signaling molecules are used by the body for very little, except for maybe psoriasis and not much else. And so, uh, if you block tumor necrosis factor, TNF, with drugs like Humira, Enbrel, Remicade, it's pretty safe, but not completely safe. Maybe there's some increased risk of infection.
Yeah.
With some of the newer drugs, the interleukin 17 blocking drugs,
Hmm.
and especially the interleukin 23 blocking drugs, you're really
Mhm.
targeting the signaling for psoriasis and not much else.
Oh, wow. That's very interesting. So,
It's very exciting.
so, wow, the immune system can have an effect on the cells, of course, because it's mediating them, right? And,
Yeah, the immune system is causing the psoriasis lesions to form. The immune system causes the blood vessels to dilate, which makes the spots red. It causes the skin cells to grow much faster and abnormally, which causes the scale on the surface.
wow, wow. Um, so recent research papers suggest that environmental pollution may result in worsening psoriasis symptoms. Is this true? Have you heard this? Should patients be concerned or do anything to mediate that?
Yeah, I appreciate you sending me that article. I think it's an interesting finding published in an excellent dermatology journal.
Oh,
And I think what they found is that there was a tendency for more flares at around times when there was more pollutants measurable in the air.
yeah.
And what that means, I don't really know, because I mean, there's some associations, not like all the flares happen there, but there was some greater tendency towards flares. Is it the pollution that does it? I'm not sure. Ultraviolet light makes psoriasis better.
Hmm.
And so, if for some reason it was less cloudy when it was more polluted, then maybe there was some relationship with the psoriasis that way.
Oh,
If people tend to go to the doctor more often when there's more pollution, or it's hard to know.
is that a special kind of UV light? Is it UVC or just general sun UV?
UVC, I think, burns things, and
Right.
we're not talking it's UVA or B, which are milder forms of UV light. And
Oh,
dermatologists will tell you that it's the UVB that's really the good one for psoriasis.
huh.
But I think UVA works too. Um, UVB per unit of energy is much more effective at clearing psoriasis, but it's also causes more burns. And so, in theory, you could go to a tanning bed and get that kind of ultraviolet light, or go out in the sun, get a combination of UVA and UVB.
Yeah.
There's a psoriasis treatment center at the Dead Sea. And the Dead Sea is so far below sea level that I don't think they get any UVB there, but people clear up there. So UVA must also contribute to making psoriasis better.
That's fascinating. Does that have anything to do with like far infrared, like the saunas?
Uh, Heat, no, not that I know of. I don't know what effect heat would have, if any, on psoriasis.
Gotcha, gotcha. Um, Now, have you ever seen a Morgellons patient or someone who believed they had Morgellons who you knew had psoriasis or another skin condition instead?
Yeah. I like the way you phrase it, who either had Morgellons or thought they had Morgellons. So I did have at least one patient. Psoriasis is pretty common. It's maybe one in every 30 people have psoriasis. And
Oh,
so if you
wow.
have 30 patients with Morgellons, you're probably going to have one with psoriasis.
Huh.
Um, and I did have one who clearly had psoriasis and clearly had something else going on that they thought was Morgellons.
Gotcha, gotcha. Um, in a recently published research paper that you co authored, it recommends antipsychotics as the first line treatment for Morgellons. What is the primary concern of a physician for prescribing antipsychotics for Morgellons patients?
Yeah, well, I think the physician's primary concern in general is getting patients well. And so that would be true here too. Uh, Again, we have to go back to what are we talking about when we refer to Morgellons disease? Morgellons disease. There are people that when physicians are labeling things Morgellons, they're generally talking about people who are psychotic and who have delusions of, for example, some sort of dragon or giant snake-like worm in their body that's releasing all these larvae that are crawling out of their faces,
Yeah.
and they this is just delusional, and those patients benefit from antipsychotic therapy. A lot of the patients that present to dermatologists thinking they have Morgellons uh, are on drugs that affect their mental state.
Yeah.
Amphetamine seems to be pretty common. Narcotics seems to be pretty common. Many of those drugs prescribed by a physician, narcotics for back pain, uh, amphetamines for attention deficit disorder. We know that people on high doses of amphetamines can develop delusions associated with their amphetamine use. And getting that under control, hopefully by reducing the amount of amphetamine they're on, may help. Um, and then and possibly using an antipsychotic to help directly with their delusions. Now, there are people who with Morgellons who may not be delusional at all. And you could say, well, maybe those people don't need antipsychotics. However, some dermatologists think that the antipsychotic medications, which have been proven effective in these people in clinical trials, may be working by a direct effect on some kind of organism.
Right.
And so there may be other reasons to choose to try an antipsychotic therapy in this situation.
Yeah, and there's 2 points I'd like to address. First of all, I'm glad that you clarified that prescription opioids and amphetamines can result in psychosis. Is that correct?
That's my understanding. Yeah.
Correct. And the second thing was regarding what you just said about the oh gosh, I just lost it. Oh yeah, about the off-label effects of the antipsychotics. There is research that demonstrates that it can have effect on some organisms inside the body.
Yeah, I mean, what do antipsychotics do? They affect the nerves. What do insecticides do typically? They affect nerves of insects, bugs,
Yeah.
more sensitive neurologically than humans are. They have a high uh, a surface area to volume ratio. We can't give humans, insecticides. They might be deadly, but, trying an antipsychotic may be an appropriate approach.
Yeah, well, and that's an important distinction to make because some people may be concerned they have organisms in them inside of them, and they may want to try an insecticide where it may be safer and with the same effect to try an antipsychotic off label.
That's right.
Gotcha, gotcha, gotcha. Um, so the matchbox sign, is there? Can you ever envision a time when people are going to be able to bring those in as they naturally do, and it have something mean something other than automatically delusions of parasitosis?
Sure. If you made a trip to South America and got bitten by some sort of insect that left its larvae in the skin and the larvae's coming out and you managed to pick it out and put it in a jar and bring to the doctor, that would definitely mean something other than delusions of parasitosis.
Right. You did your residency at Duke, is that right? Or you attended Duke?
Yeah, I went to medical school at Duke, did
Gotcha.
dermatology training at Chapel Hill, to in conflict places, and then a year of skin pathology training down in Charleston.
And Duke is also where they have an excellent uh, parasitology course that anybody can take if they'd like to get a little familiar with what actual bugs or worms or could be out there that could infest your body.
Yeah, I
So,
haven't heard about that in a while. That sounds like a fun course to take. There's a researcher at Harvard who has uh, I think, a business on the side. I can't remember. It's something like Identify My Bug. Um, and
oh,
people can send that lab samples, and they will tell you what that bug is.
well, now outside of bugs, what about like skin artifacts? Are there any conditions where it would be reasonable and understandable for a patient to pick at their skin, like warts, blisters, or pimples?
Oh, people do pick at skin lesions. Skin lesions, uh, if they itch, people will scratch and dig at them, even if they're just there. I, uh, I've been exercising some, get calluses here on my hands, and my
Yeah,
wife is forever telling me, "Stop picking at that." and the fact that it's there, just my brain wants to go at it.
sure. So the problem isn't that people are picking or that they're bringing you something, it's that these beliefs that they have are preventing them from engaging in life. Is that right? It's affecting their life in some way that's of detriment to them or their families.
Oh, I think that's a really good way to describe at least some of the patients.
Some of them,
Some
not
of the
all of them.
patients who have delusions, like those who are on amphetamines, and they think that there's worms crawling out of their skin when there are no worms there, and they're there with tweezers digging at it in
Yeah,
front of you, and they're causing scarring and maybe super infection on top of whatever it was there. Um, and it's interfering with their lives, and they're very distressed about it. I think that describes those folks really well. I think there may be some people who have either something coming from inside from their immune system, possibly some sort of bacterial infection in their hair follicles that itches a lot and they dig, and then there's drainage of serum from the open tissue that congeals and traps fibers there, and the patients can see the fibers and they think they've got some sort of fiber induced dermopathy. I don't know that that's psychotic. I mean, I think that's real. If it's affecting them so much that they're depressed about it,
yeah.
maybe some sort of psychological evaluation would be helpful.
Yeah, and often these conditions, when they result in ulcerations in the skin, and the skin really protects us from outside infections. So when it's compromised, that's opening us up to opportunistic infections. But when we do have problems with the skin, people tend to want to isolate. They feel like they can't be around people that they look bad, or they feel bad about how they look.
Yeah, we know about that from psoriasis. Psoriasis, you've got these red scaly lesions, and one of the most bothersome aspects of the disease is how it how isolating it can be. How you it affects people's perceptions of themselves. It affects how other people perceive you. It affects how you perceive other people perceiving you. And I think that's true for
Yeah.
eczema and for acne, for various scarring conditions, and certainly for open wounds on the skin.
What is atopic dermatitis? That's not on our list of questions, but I'm just curious.
Yeah, atopic dermatitis is another common skin disorder. I think of it as sort of being like asthma of the skin. It's like the skin is just too sensitive to the normal environment. So you get a reaction in the skin that looks a lot like allergic contact dermatitis, but as far as we can tell, there's no specific allergen causing it.
Oh, gotcha. Um, so how much, in your opinion, does online misinformation play into the role in patients you see who may need to be on antipsychotics?
Um, I like information. I love the internet age. I love when people go out and educate themselves on what's there prior to coming to see me. If they have psoriasis and they've learned all about psoriasis options and they know what they want, that's great. Um, do I see much misinformation? I think there probably some, and I think it stands out more in doctors' minds than all the, when patients educate themselves that from reputable sites, whether it be on, the CDC website about COVID or,
Yeah.
I think we don't tend to pay much mental attention to it. When somebody, decides, I don't need to be vaccinated, I can just take ivermectin,
Yeah.
then that stands out in our mind as a problem.
Yes.
Uh, right now, that the information and potential for misinformation, I think about COVID comes up in my dermatology practice more than misinformation about skin problems.
Wow. Yeah. I think I've seen that trend also. Morgellons is just kind of fallen to the wayside as everybody picks up a lot of ideas about the coronavirus. Yeah, you're right about that. Um, okay. What about cannabidiol oil? Do you think that can be a good substitute for antipsychotic medications? And are there any skin conditions that you feel you could be treated or managed with cannabis as a first line treatment?
I don't know that we have any good data yet. There are cannabinoid receptors in the skin, and I think there's some research going on looking at cannabinoid receptor based drugs that work through the cannabinoid receptors to see if they have a beneficial effect on itching in the skin.
Right.
And I think that if there's going to be a condition, that doctors are going to have good evidence that it can be treated with CBD or something like it, I think it's going to be itching. Whether other things respond well to it or not, whether it has anti-inflammatory effects that might work for eczema or psoriasis,
Mm.
I don't know yet.
Gotcha. Well, if your state passed a medical marijuana law, then would you be open to writing recommendations for your patients?
Someday, if there was good evidence that marijuana was an effective treatment for, if there was a well-controlled trial showing that it was effective for some skin disease, sure, and if there weren't, then no, I'd leave it to the patient's primary care doctor to manage things other than skin involvement.
What about for psychodermatological conditions, if the research was there?
Yeah, if the research was there, sure. I mean, if somebody came and said, you know what, I'm picking at my skin, I can't stop. I think
Mm.
it's an anxiety disorder. I've already seen psychiatry; they haven't helped me. If there was a study showing that marijuana helped that, and there was appropriate legal, use of it, I think that would be an entirely reasonable thing to try.
Commendable. Well, let's talk about this Dermatology Advisor article that suggests that there may be a real Morgellons condition that involves human biofilaments. I think we talked about that earlier, artifacts getting stuck in exudate. Um, is this paper substantial, though, to validate a real Morgellons condition, in your opinion?
No, I don't think so. The I mean, we know these fibers are hair-like, containing keratin, according to the people who study Morgellons and believe in Morgellons and think that the body is producing these hairs, these fibers, they'll call them.
Yeah.
To make a fiber, a visible fiber like a hair, um, the body has a hair follicle structure. It's got a root ball, and the root ball produces the hair. The hair doesn't just miraculously appear out of nowhere. Fibers don't just miraculously appear out of nowhere. But these researchers seem to think they can, because, I mean, all it would take is to show one biopsy showing a follicular, the structure that's making these supposed fibers in the skin. And there's not a single biopsy that shows that there's any kind of fiber formation in the skin of people with Morgellons disease. So I suspect that the fibers are probably caught in there because of the sticky serum that develops in open wounds. When the body has an open wound, it needs to seal that up. So protein fluids come out of the blood and the lymph. They coagulate in the area. They form almost a super glue-like seal on the surface. And your own hair or hairs from clothes could easily get caught up in that. And I think that explains how you could have multicolored, fibers described. The idea that these multicolored fibers are formed by the skin itself with no follicle formation to be seen anywhere just seems patently ridiculous. And, that alone, I think, is the logic of it is what makes me think that these people just don't know what they're doing. When I look at the list of people doing this research, I don't see people, at Harvard, Yale, the NIH. They did a big study and they didn't find anything to suggest that Morgellons was a specific real condition caused by fiber formation in the skin.
Right.
One of the investigators, the lead investigator on the study, if I'm not mistaken, was doing HIV research, decades ago, and was found guilty of scientific misconduct and was temporarily excluded from getting grants because of the scientific misconduct, and I think resigned a position at a research university. I just don't think any of it makes sense to begin with, these research studies. The other thing, the research studies, they look for infections. Now, if you have an infection, one of the signs is you will find a specific organism causing the infection. When these people look, they find all kinds of, it's like everything they look for is positive. That's a sign to me of non-specific results, not a finding of a specific cause for a disease.
And so these are the common rebuttals to this research. Can we take them one at a time? Not spend too much time on them.
Sure.
The first one was the biopsy. There was a biopsy which demonstrates the Morgellons fiber growing from a base pavement of epithelial cells. Is that just
by chance, can you pull that picture up? We can take a look at it together.
Yeah, I can do it right now, actually.
Excellent.
All right. And also regarding the individual who was disciplined, if I'm not mistaken, they had a belief that only gay people would develop the HIV antibody. And because of that, they left out people who had the HIV antibody. That's what I read in the disciplinary report. Basically, it was selection bias, if I'm not mistaken.
Yeah, I think it was selective presentation of data, so that they found stuff that went against what they said and they didn't show that. It would be as though, maybe, if they had found stuff that went against their belief that Lyme is a cause, they just wouldn't show that stuff.
Gotcha. All right. What I'm pulling up now is classification and staging of Morgellons, lessons from syphilis. This study was published in 2020, but I believe the image I'm getting ready to show you appeared in earlier research. Yeah. Let's see. All right. I'm not sure if I can share my screen or maybe just get out of the way so you can see it here.
Yeah, I I uh, I see on
Yes.
what could easily be a fold in the skin or some kind of of um, of hyper hyper staining of some of the skin cells, and there's no follicular structure. There's
Right.
no bulb. There's no surrounding follicular epithelium. There's just
And I
it.
apologize if this is the first time you've seen this, and we didn't want to pull any gotchas on our interview here, but I can send this to you so you can take a look at it.
Yeah, if you could pull it up right now. I'm looking for that article. Again, you said it was the title was
Yeah, classification and staging of Morgellons, lessons from syphilis. And the stain is anti-spirochetal. I'm sorry, spirochetal antibody stains. It stains for a broad range of spirochetes, including Borrelia and treponemes.
yeah, I'm not seeing that art. I see the history of Morgellons disease article. Did you say you found it there too? Yeah, here's the same photograph.
Yeah.
It's in figure 2 of the article. It shows what they're claiming are filaments, and there's absolutely no follicular structure, creating these things. There's no collection of cells along them that are forming these fibers. It's just fibers that are stuck in there.
Yeah.
Um, there's so the photographs are completely consistent with some sort of foreign fiber that's present, and completely inconsistent with the body making a fiber at that site.
Well, I guess the question then would be, why are they staining for spirochetal antibodies? Why are they reacting to that stain then?
These people who are doing these studies find what they want to find, so if you if you pull up a picture of one of these spirochetal stains, you'll
Yeah.
see this gamish, this mess. And let's see, is the same article have the spirochetal stains?
Yeah. Yeah. The methods are all listed on there.
Yeah. So if you take probably any piece of tissue and stain it up, you can find non-specific stuff that you can claim. Oh, I think that's a spirochete. Uh, and unless you have really good controls, uh, where you've blindedly looked to see if in the disease you see it and not the disease you don't, then you can't say that these. You wouldn't even want to guess that these things would be truly positive. But more than that, the finding that they find every kind of spirochete. If it was a disease caused by a spirochete, you would find a positive result for that spirochete and negative results for others. They find positive for everything they look for. It seems very non-specific.
The other research paper was detection of tick-borne infections in Morgellons patients, and they looked at other spirochetes and other tick infections, and they weren't able to demonstrate co-infections in the entire cohort, but they did find just as much relapsing fever Borrelia, which is what I have. I don't have Lyme disease. I've got tick-borne relapsing fever, as they did Lyme disease Borrelia. So my understanding, and I've interviewed the some of the researchers on the show as well, and I have great respect for them. But my what they've said is that it seems to be limited to just the Borrelia species, and Treponema denticola. That's common. If you have cavities, right, you're going to have a possible exposure to that pathogen.
Well, then it's not just possible exposure. They're saying they see it in the tissues of these people.
With a scanning electron microscope,
Yeah,
not
yeah,
with the naked eye. No.
yeah.
Well,
So, I mean, they may be just seeing junk in this electron microscope and interpreting it as some kind of treponeme. Because what if maybe you have it in your gums? I doubt you have it in your skin.
uh,
Um, and in this, when you say they find Borrelia species, they're finding multiple Borrelia species in the same person.
no, not in one individual. I know for sure they found both. But that's not true of the entire cohort. I believe there's only one or two patients out of the cohort in that particular study which did. You just stated that. I'm sorry, there was something else I could have. The dissemination. There is one recent research paper which demonstrates Treponema denticola does disseminate into the body, into organs. It doesn't demonstrate that it disseminates into the skin, however. Thank you for giving us your analysis on this paper. I think we understand that, if I'm not mistaken, that this research would have to be accomplished outside with some people who didn't have a controversial background and who were
No,
affiliated.
no. Good research could be done by anybody. I
Okay,
could do it. You could do it. If there's good controls, blinded negative controls that find that find that when you do the test and the stuff isn't there, you don't detect it.
gotcha.
When you throw these PCR tests on there, polymerase chain reaction tests that are extraordinarily sensitive, you can make those positive by accident very easily. And I think that's why they find all kinds of things that they want to find.
Yeah, and at the same token, PCR isn't a silver bullet. Sometimes it's not accurate in finding what is actually there. Is that right?
It's extremely sensitive for finding things that are there. Uh, but it can be very non-specific and find stuff that isn't there if you're not careful and don't have
Wow,
good controls.
that's cool. I didn't know that.
Yeah, it's so sensitive. It can detect tiny little pieces of DNA. It just have one little piece of DNA and it duplicates it, duplicates it, duplicates it until you have so much of it that you can find it. My laboratory years ago did PCR research, and there was a technician, and you would set up the experiments in one room, and then you would examine the specimens in another room, because when you that examined specimen has a billion copies of that little tiny piece of DNA that you're
Huh.
looking for. And if any of it gets into the air, it can contaminate your specimens. So you have to set things up in one room and then do it in another room. One of the technicians was working on a project for a faculty, and he thought there was wart virus in some lesions.
Huh.
And she did the PCR and did not find any wart virus. So she says, well, he really thinks that they're there. So she repeated it. And sure enough, when she repeated it, it became positive. Well, in the process of repeating it, you're taking stuff from the contaminated lab and rerunning it, and it could have gotten contaminated so easily because there's so much of this stuff flying around. If these people
Oh,
think that there's Bartonella there and they want to find it, and they're using PCR, unless they're doing it in very stringent, careful ways with really good controls, they'll find what they're looking for and report it. And if they have somebody on the team who's used to who has a history of not telling you the stuff that doesn't that contradicts what he wants to find, that just adds to my skepticism about it.
yeah, that was my point. Was that it's just it makes the research hard for people to accept because of that issue. It could be that they're only finding Lyme disease patients or have propensity for this because maybe they're leaving syphilis patients out. And not saying that's what's happening, but that's what some people may think because of the circumstances.
Well, I think that mainly they're thinking it because they're finding multiple different species. That doesn't make any sense if it's a specific infection, that they don't include controls. They don't show you negative controls, that they're not blinding their research. All of those things, I think, would be the main reasons not to believe it. The fact that the researchers, was found guilty of this kind of scientific misconduct that would lead to misreporting, it just adds to the problem. But the
But
primary problem is they're saying stuff that's just ridiculous. Like, we have a fiber here, and these cells are making it when there's no follicular structure present to make a fiber. I mean, that's just ridiculous. And I think they're just totally misinterpreting what they're seeing because they have a predetermined view about this that they're trying to support And we know that this is such a common problem today with humans in general, and the politics of things and how people interpret,
Oh,
attacks on
confirmation.
the Capitol and stuff. Yeah,
Yeah.
these people, the confirmation bias is something that's real, and I could certainly be guilty of it in thinking that my predetermined views on delusions, are what they are. But it could certainly affect researchers and how they view their data.
Yeah. So, well, there is a path to produce research which would be acceptable, though.
I would think so, sure.
Very cool.
I think the CDC study that was done back, I think it was in 2011, where
2012.
they look. I'm sorry.
It started in 2008, but it was published in January 2012.
Excellent. Yeah, it's a fabulous study. It was well done with controls, and I don't think they had a predetermined thing that they were trying to find. They were looking to see if they could find signs of something. And well, one of the things they found was that a lot of the patients in their study with they thought was going to be Morgellons were on narcotics and amphetamines, and so at least a subset of those populations may have had some sort of drug-induced condition that made them think they had Morgellons.
It's funny though that same CDC study did also find that all participants included at the end of the study had a positive or equivocal Lyme disease test without any confirmation testing, but all 12 of them had positive or equivocal Lyme disease serology.
Let's go back because there's 100 people in that study. I don't know what you mean by all of them had positive Lyme titers.
There was only 12 included at the end.
So let's see if I can pull up that study real quick because that's such a key study.
Yeah, and thank you for making time to analyze this with us.
Yeah. I've got so many Morgellons papers here. Let's see if I find that. Oh, here we go. 2012 CDC study of Morgellons. And make this a little larger. And okay. And then we'll just find the Lyme sections on it.
I think they term it as Borrelia burgdorferi.
Borrelia?
Or B. burgdorferi.
At CDC, serum samples were tested for the Borrelia toxocara strongyloides. So that's in the methods section. Clinical evaluations, neuropsychiatric assessments, biopsies of impetiginized skin lesions, fibers which consistent with cotton, evidence of dyes, so it's dyed cotton, some nylon.
The majority of them, they did find that I think 24% of those were superficial skin.
There's culture results, histopathology, biorefringent material. Here we go. I think this is where we're going to see no case patients had hepatitis B antibodies. One patient each had positive or borderline for Borrelia burgdorferi. None had a positive Western blot.
No confirmation testing, but initial ELISA was all positive. Yeah.
Yeah. So the initial ELISA was positive or borderline in one patient each. One patient out of the 100 that in the study had a positive borderline, had a positive Borrelia test. One had a borderline ELISA, and none of them were positive on confirmation testing.
Yeah, they didn't do confirmation testing on those.
So the Western blot was the confirmation, and none of them were positive on the Western blot.
I believe if you look at the methods, they didn't administer the Western blot.
It says here none had a positive IG Western blot. So let me go back to the methods for you. Control find WB Western blot.
And that could also mean that they had syphilis, because syphilis will result in a false positive on a Lyme test, but Lyme will not result in a false positive on a syphilis test often.
Yeah, so it says that the seroreactivity was determined using the ELISA, the enzyme immunoassay, and separate IgM and IgG Western blot.
Okay, my bad. I was
yeah,
wrong.
and
Yeah.
so we had one or two positive on the ELISA and none on the Western blot.
But is that 100 patients were tested or just 12? And if it was just 12, then why do they say one patient each? My understanding is only 12 made it to the end.
Let's see if they specify how many of the 100 patients had those tests. Met case definition, 115, 109 agreed to participate, 70 completed a web-based survey, 41 participated in the clinical evaluation. Let's see, it should be maybe here, laboratory tests. Few case patients had abnormalities. It sounds like it was out of the 41 had the clinical evaluation.
Yeah.
Because they have hair samples on 40, and at least one drug was detected in the hair samples of half the patients, including our amphetamines, barbiturates, benzodiazepines. Of course, it was California, so a lot had cannabinoids, cocaine, opiates. You know, I think there's a whole lot more drugs in here. And I'm not saying they were necessarily drugs of abuse, as you say. As you noted, we were saying that these could have been prescribed medicines, but amphetamines, barbiturates, the opiates, and the benzodiazepines were the most common, followed by the cannabinoids and the amphetamines. You could add the amphetamines and cocaine to be pretty common. Those seem to be much more common than any kind of positive Lyme test, Borrelia test.
Hey, thank you for making time to analyze that. I'm sure a lot of people are going to go back and actually pull that up and look at it because we were talking about it today. So, are there any known skin conditions that result in fuzzy sores?
I'm not sure what you mean by fuzzy sores, but any kind of open wound where the serum congeals, if it's got exposed to clothing, fibers, dust, that stuff can catch in the serum and end up with a fuzzy looking surface to that sore.
Gotcha. Oh, in the movie Skin Deep, you mentioned that one of the symptoms being shared with you looked like warts. Can you tell us what was going through your mind when you saw those pictures?
I'm not sure. They could have been, they had shown some sort of thing that in animals it was fibrous, and I don't remember what human pictures they showed it, but warts are pretty common things. And if, a wart has this finger-like growth of the surface of the skin, we would call it digitate if we looked at it under a microscope. And so you get this warty growth, almost a little more spiky than a cauliflower. And it may be that they showed something that looked like that.
Yeah, this was the bovine digital dermatitis comparative study. And underneath a lot of patients' scabs, the hair follicles will fill up with collagen and become slightly keratinized. And when they pull the scabs off, those casts come out with the scabs. They adhere to the scabs. I think that's what you were looking at.
Okay.
And thank you for elaborating on that. If a physician observes filaments, there was a recent study that was independent from the researchers that we discussed earlier, which looked at treating Morgellons with doxycycline. In there, the physicians state that they observed fibers. What, in your opinion, were they really looking at?
So there's a figure 3 that says skin scrapings revealing fibers and debris collected from various lesions. And it looks like scale off the surface of the skin for the most part.
Yeah. Superficial skin, would you call that?
Yeah, I mean, like the scale you see in psoriasis. It looks a
Oh,
lot like what I might pick off of my callus right here.
gotcha. Um, do you feel like testing patients for Lyme, relapsing fever, and syphilis may help improve the patient relationship, or do you feel like that could backfire and exacerbate it if the tests are all negative?
Oh, I don't think it would exacerbate things if the tests were negative. Uh, I think if a patient wanted Lyme testing done, then doing it might improve the patient relationship. I don't see how it would hurt anything.
Yeah, especially if insurance is covering that test.
Yeah,
Gotcha. It
yeah, I
can be a
guess.
problem.
Yeah, can be a problem. Yeah, when you nowadays when we put in our orders for tests, we do it electronically, and we assign diagnoses for why we're doing it. So if we want to do a thyroid test because the patient is tired all the time, we put a diagnosis of fatigue in, and the insurer's computer looks at it and goes, they're doing it. They want to do a thyroid test. It's for fatigue. Oh, okay, that makes sense.
Yeah.
We'll do it. And you know, if there was no diagnosis that made sense for that test, I could see how an insurer might not want to cover it.
Yeah, gotcha. Well, it could become a problem if, especially if a patient isn't engaging insurance and they're just trying to pay out of pocket. That could become a an unnecessary financial burden for them and potentially their family.
Yeah, one of the great things nowadays is to get on goodrx.com when you get a prescription for something and see who's got it at the lowest price and maybe use the GoodRx discount. I don't, there must be, I wonder, if there's something criminal about this, but it seems very valuable. People might spend hundreds of dollars on something they might could get for $20. I don't know if there's an equivalent of goodrx.com for laboratory testing. But if I were having something expensive done, like when I got a CT scan for my back, I looked around to see who would have a decent price on it.
Wow. Yeah, and that's good to have that flexibility so you can shop around. Is everything okay now?
No, backs are never okay.
That's what I hear, man. Um, do you ever have to have a patient on long-term antibiotics? Are intramuscular or intravenous antibiotics ever required in dermatology?
Uh, Required, I don't know, but one of the most common treatments for acne is an oral antibiotic, and I
Oh,
think there's been an effort to try to get people to cut back on that to avoid bacterial resistance and the
yeah.
overuse of antibiotics and the potential side effects on gut bacteria. So, but we
Hmm.
still give people long-term antibiotics for that. Sometimes other inflammatory diseases, rosacea, redness of the face,
Yeah.
long-term doxycycline might be used. And for people who have rare autoimmune mediated diseases, sometimes the anti-inflammatory effect of an antibiotic might be the safest available treatment for patients.
Wow. Have you heard about the new artificial intelligence app that can diagnose skin conditions from just pictures? Are you concerned about your job?
I am not concerned about my job, but I believe that such thing. First of all, if I was doing this, I'd not start with an artificial intelligence program. I would just start with dermatologists in India who must not make as much money as an American dermatologist, and I'd send my photographs to them and let them do the diagnosing. There's probably state laws that make that illegal. I'm more of a libertarian who thinks, listen, if somebody wants to get somebody else to look at it, that's great,
Right.
Uh, but I realize, especially at my age, my eyes don't work that good. My iPhone sees better than my eyes.
Yes.
I am certain that it sees more wavelengths of light. It can recognize infrared and stuff that my eyes can't even see, and can do so with quantitative accuracy that I can't do. And so I'm pretty sure that the supercomputer in my iPhone has
Right.
more brain power than my neurons. I have no doubt about that. So I'm quite confident that it should be able to diagnose and plan treatment for people better than I could. It should happen. When exactly it'll happen, I don't know. But I'm not worried about my job because patients aren't going to trust that iPhone. They're going to want to see a doctor.
Especially when that iPhone makes a couple of mistakes, right?
Yeah, well, but I make mistakes too. Plus, I'm so close to retirement anyway that by the time it happens, uh, I think it's going to be good. Uh, yeah, maybe horse and buggy people were afraid of gas engines, but that's okay. Life moves on. If the artificial intelligence programs do it better,
We're just about done with this too, though.
Live streaming is on.
Okay, so bottom line is you don't have to worry about anything because we're probably about 10 years out from the robots taking over.
yeah.
Very cool. Dr. Feldman, what are peptides, and are there any FDA-approved peptide therapies?
Yeah, so peptides are small chains of amino acids. Amino acids are the building blocks that we make proteins out of. Peptides are just small, short proteins. And there are some peptide treatments. For example, insulin is a peptide. And it's maybe on the longer side of calling it a peptide before you call it a protein. I think there are some shorter peptide drugs, but not in dermatology. But yeah, there are peptide therapies available. Insulin would be a good example.
Cool.
I think
cool.
some of the other things, some of the growth factors that they would use in bone marrow transplant patients to get the bone marrow working again, maybe protein peptide peptide drugs as well.
I believe there was one recently approved peptide therapy for photosensitivity disorder.
Oh, I'm not familiar with it offhand.
I'll have to send it. That's Clinuvel. How do you feel about the potential role of gamification towards patient compliance? That's where you're rewarding patients with like money or points to take their medicines.
Yeah, I love it. I think anything that gets people to use their medicine is a good thing. And some examples, I had foot fungus from doing Taekwondo, barefoot.
Oh,
And I
wow.
could never remember to put my antifungal cream on until I put the cream on top of my socks in the drawer. And then I never forgot to do it
Oh,
because it would always remind. Otherwise, if I put it anywhere else, I'd put my socks on first. Packaging is a great way of improving adherence. Birth control pills work great because of the packaging. It tells you which pill to take which day, and so you could see whether you took it or not, and it makes you use the medicine better. That's great. If you have an iPhone and you want to remind yourself, that can be helpful. Although, if my iPhone reminds me to do something and then I walk across the house to do it, by the time I get across the house, I forgot why it is I came across the house, and I still don't do it. But yeah, if gamification, especially you think for acne patients, to get them to use their medicine better, it makes a whole lot of sense to me. I've been studying Spanish on Duolingo, and
oh,
the points I get each day and keeping my going is a major factor in keeping me adherent to my Spanish training.
Duolingo is a very cool app for learning a second language. Yeah, I'm glad you're engaging with that too.
Yeah.
Um, so how do you feel? What about steroids and hormones? Do you ever use those in dermatology?
Oh gosh, yes, we use steroids like all the time.
Really?
Corticosteroids, the ones that your adrenal gland makes, like hydrocortisone. Your body's making hydrocortisone every day coming out of your adrenal gland. And we use hydrocortisone for face rashes. We use stronger versions of hydrocortisone, other forms of cortisone, for inflammatory diseases. Like we use the mid-strength cortisones like triamcinolone for eczema. We use the super strong cortisones like clobetasol for psoriasis. But there are other hormone things we do. We give birth control pills for acne because the male hormones, the androgens, cause acne. And in women, you can suppress those male hormones with birth control pills.
Oh, wow.
So can't use them in men, but in women we use that, or spironolactone can be used to reduce androgens for women with acne-like problems. The retinoids we use, Retin-A for photoaging or for acne, or the over-the-counter adapalene, they are a form of hormone therapy as well.
That's fascinating. And so men with testosterone, do they often come in because of acne if they're getting testosterone therapy?
Men, no. Well, there may be some of that. That's not the most common thing I see. The most common form of testosterone-induced acne I see is normal adolescents.
Gotcha.
Just from their own natural testosterone. And the other thing that we see due to testosterone, or really dihydrotestosterone, is male pattern baldness, as you can appreciate here. For guys who want to keep their hair, there are drugs, Propecia or finasteride, that block the conversion of testosterone to dihydrotestosterone and can help guys keep their hair longer.
Oh, wow. Is that a topical or a pill?
Pill.
And does that also work for women too?
I believe it does. I don't know that it's approved as a treatment for women, and I don't know that we have quite as much data, but it's approved for men, and I believe that my partner who specializes in hair loss does prescribe it for women.
Oh, commendable. It's okay. Do you ever have to refer a patient out for serious treatment like surgery? What skin conditions are going to signal you that may happen?
Yeah, I don't know that surgery is necessarily more serious than some of the medical treatments we use for severe skin diseases. But that said, do we refer patients for surgery? Yeah. A lot of dermatologists are expert skin surgeons as well. I'm not so much. I can do a little tiny biopsy, but if you needed, a little skin cancer cut off the face, I refer to my partners for that all the time. If somebody had let a skin cancer grow to the point that it's eating off maybe half of their face,
oh my God.
Then we're going to send you to an oncologic surgeon, maybe who will work with a plastic surgeon to take off some massive cancers.
They start there on the nose kind of often, or?
Yeah, one of the things I could consider telling a patient is, you may want to think about wearing a hat and using sunscreen, keeping the sun off your face so that you don't get some golf ball sized tumor of the nose that's dripping pus and eating away into the skin, where the surgeons would have to cut off the entire nose, leaving a gaping hole in the center of your face. But not to worry. The rubber prostheses they make nowadays look pretty good. I don't see that very often. Most people, when they have a little skin cancer, it's a little tiny thing that we can relatively easily remove. Either I could just scrape and burn it off, or send to a partner who under local anesthesia can remove it and move some skin into place to close it up.
Well, nowadays people are more aware that that's something that can be taken care of, and they have the resources to get in touch with you to get that done, right?
Yes, I think so. I think, when it comes to resources, people, if they've got a problem, should try to be seen. So in my practice, I've had patients with horrible psoriasis who delayed coming in because they said, I didn't have insurance. I'm like, you didn't have insurance? I love taking care of patients without insurance. I can get free drug, the most effective drugs in the world for people with bad psoriasis for free, for people who don't have insurance, who don't have good incomes.
That's good to know.
Yeah. So if you're having, if you have some sore that won't heal, and it might be a melanoma, I'd go to an academic center, maybe investigate ahead of time what it would cost. But I would never want financial. We live in such a great country. I would never want financial burden to affect people's access to treatment.
Positive mental attitude goes a long way, right?
Yeah, we have a lot to be thankful for. We're living now in the best of times. I mean, compared to living in a cave and digging in the dirt for worms to eat, I would say we're doing pretty well. And, if your listeners are in the United States, gosh, not only are you living in the 1% best of times, but you're not in, Africa, India, you're in the top 1% of places to be. And if you're like me, you're a doctor, man. you're in the top 1% of Americans in terms of lifestyle and stuff. I got nothing to complain about.
But you did a lot of hard work to get there, though.
I guess I think some people are just designed to just work like, day and night. And that's, I think that's what humans were designed to do. I think part of the ennui is not having enough to do,
Yeah, exactly.
and because during evolution, up until the last 50, 100 years, leisure time did not exist. I don't think we were genetically programmed to enjoy leisure time.
Well, it'll pick back up when we go back out into space, start going real far out there. Dr. Feldman, thank you for making time to be here with us today. And on the last note here, can you tell us the sun, since we're talking about space, is it really what causes skin aging ultimately?
Oh, absolutely. I want you to go and find the oldest relative you can with the most beat up, wrinkled skin you can find, and then look at their underarm. It'll look like a newborn baby.
Gotcha. But we need that sun to treat the psoriasis too, right?
Yeah, sun's a great treatment for psoriasis. If you have psoriasis on the body, I think sun is one of the best treatments. It's like what the Bible said to use. The Bible is inerrant, maybe, but maybe the translations are wrong. So when they said they sent the lepers in the desert and the leprosy cleared up, I think they were talking about psoriasis. Maybe somebody mistranslated the word from whatever the original language was in Aramaic or to Greek to English. Somehow psoriasis got turned into leprosy. But I would tell people, keep it off your face because most of the skin cancers occur on the face, and try not to burn.
So maybe do a light sunscreen, like with the low SPF, or
if you're treating psoriasis, you want some direct light on there.
Gotcha.
Maybe you could sunscreen the surrounding skin if you wanted to really take the trouble.
Very cool. Very cool. Dr. Feldman, that's the conclusion of our interview today. Thank you so much for.
Oh my goodness, it's always a pleasure talking with you.
Likewise, definitely. And we definitely hope to have you back on the show. If you want to, you can reach out to Dr. Feldman, his office there, if you'd like to become a patient, especially if you have psoriasis. And he's one of the nation's leading experts on psoriasis. And I hope everybody had a good time. And we will definitely look forward to seeing you back here soon. Goodbye, Dr. Feldman.
Bye-bye.